Hey guys, we are back again, and let's see, what are we learning about today? Oh, neurocognitive disorders. So, this is another one of those chapters where I am going to go through the disorders. We are going to get a brief overview of each of these disorders. However, geropsychology, or that is the psychology of neurocognitive disorders and aging, is and should be an entire class on its own, right? There are people that specialize in working with older adults, and there are just so many things that go along with this. Okay, here, let's do this. Okay, so with the neurocognitive disorders, okay, we're talking about things that involve the cognitive decline. Cognitive decline, to you, it will look like intellectual decline. It will look like the person is losing their ability to live independently and function independently, remember things. All of that is what we mean when we talk about cognitive decline. Okay? So these disorders involve cognitive decline that is acquired in life in one or more domains of cognition, right? So all those types of things, functioning independently, kind of information you'd learn in school, memory of social medical history, things like that. Okay, what we look at is we look at the concerns of the client, or, and often, someone who knows the client well. So we may really want to do a lot of interviews with others to find out how did they function before and how are they functioning now. We may see someone who seems to be functioning quite well, but what we don't know is before they were functioning fabulously. Okay? We want to look at the performance that they have on assessment measures. So we have a lot of neuropsychological assessment measures. The one that I use that we'll talk a little bit about is your simple, basic MMSE, which is that mini mental state exam. Okay. The DSM provides descriptions to help clinicians, people like me, provide a diagnosis that indicates both the fact that the individual has a neurocognitive disorder and where and what the possible cause might be. All right, so let's talk about these. In the DSM-5, we replace the word dementia with the term neurocognitive disorder. Okay, so neurocognitive disorder. It refers to a form of cognitive impairment in which individuals undergo a progressive loss of cognitive functions. It needs to be severe enough to interfere with normal daily activities and interfere with social relationships. Now, clinicians are still going to use the term dementia, right? However, the DSM-5 work group considered dementia to be useful in settings where more medical personnel are familiar with the term, so we may still use the term dementia, but technically it's, quote, neurocognitive disorder. All right. Now, when we look at neurocognitive disorders, you want to know that this is how you diagnose. You diagnose either a major neurocognitive disorder or a minor neurocognitive disorder. Okay, you'll want to know that for your exam, the difference between the diagnosis of a major neurocognitive disorder and the diagnosis of a mild neurocognitive disorder. Okay, here's the big difference. A major neurocognitive disorder involves significant cognitive decline from a previous level of performance. Okay, that means a significant decline, something where people really notice a big difference in their ability to function on a daily basis. A minor neurocognitive disorder involves modest cognitive decline, so maybe they are having issues, but they're still able to go to work, or they're having issues, but they're still able to interact and function socially. Okay, that major neurocognitive disorder really means it's interfering with their life. The minor neurocognitive disorder means there's an issue, but it's not significantly interfering with their life. Okay, next term, delirium. Okay, so delirium, we're going to need to know the difference between delirium and dementia. So delirium is a temporary state. Okay, and that's that word you really want to think about, is that temporary state. It's a neurocognitive disorder that is temporary in nature. It involves disturbances in attention and disturbances in awareness. It's a temporary state in which individuals experience this clouding of consciousness. Maybe they're a little unaware of what's happening around them. Maybe they're unable to focus or pay attention. This is the other word. Aside from temporary, you want to remember the word abruptly when you're thinking about this. If you're a flashcard person, you'd write delirium, temporary, and abruptly. Okay, with dementias, they come on slowly. With delirium, they come on all of a sudden. They do tend to fluctuate over the course of time that the person has the disorder, but it comes on all of a sudden. So a delirium may be due to a psychological stressor, and may be due to a medication issue. If you know an older adult who is in the hospital and all of a sudden seems to have what they're calling dementia, but it came on all of a sudden, really ask people to look at their medications. See if when they are not in a hospital setting that they're better all of a sudden. Delirium comes on, and we really need to kind of see what's going on with that to make sure that that can be fixed and not just called dementia and then they ignore it. Okay. So like I was saying, it develops for a variety of reasons. Maybe because you are using drugs. Okay, maybe because you were using drugs. Maybe because you bumped your head. Maybe because you have such a high fever, you're kind of losing it. Maybe you have a vitamin deficiency. Okay, maybe there's a medication issue. Those kinds of things. People of any age can experience delirium, but it's really quite common among medically or psychiatrically hospitalized older adult patients. Okay. Maybe because infection, central nervous system disorder, metabolic disorders. These are the things that we're going to use to kind of see what's going on. These are antipsychotic medications, the haloperidol and the risperidone. But we're really going to kind of see, can we all of a sudden switch this? If we make one alteration, does this person come out of the delirium state? And if so, then we know it's delirium and not a dementia. Okay. Now, Alzheimer's disease. We are going to talk about Alzheimer's disease right now and then again just a little bit later in the lecture. But I think it's important to know that not all dementias are Alzheimer's disease. Okay, when we talk about dementia, that doesn't necessarily mean you have Alzheimer's, but Alzheimer's disease is a dementia. It is a neurocognitive disorder, right? This neurocognitive disorder is associated with progressive, right? Progressive gradual declines in memory, progressive gradual declines in learning, and at least one other cognitive domain. Okay. We have this progressive and gradual. And this is, so again, if you're a flashcards person, you want to write down Alzheimer's, and then you're going to write down progressive and gradual. If we were thinking about, if we had a chart, we would have, basically you'd have this sort of progressive line that went down like that. Okay, it's progressive, it's gradual, cognitive decline. due to, well, honestly, severe cerebral atrophy. And again, we're going to talk in a minute about exactly what's going on in the brain, but we do call this one a major neurocognitive disorder. Okay, we have stages of Alzheimer's disease. We have what we call not Alzheimer's, early stage, middle stage, and late stage. And there are different symptoms that go along with each stage. If you want to learn more about that, absolutely go to your book. You can go online. All of those things are good. Factors related to more rapid decline in the early stages of the disease include being younger at age of onset, having higher education, having poorer cognitive status when one first identifies the symptoms, which may mean that they didn't identify them when they were first actually happening. Now, this doesn't mean don't get higher education because of this. This doesn't mean this will cause you to have Alzheimer's. This means that you see a more rapid decline in early stages of disease with these particular correlational factors. Okay. Since early detection is really important, a lot of diagnostic tests have been designed. However, we do a lot of these are neuropsychological testing, and like I mentioned, the mini mental state exam. We do have some brain imaging techniques also that you can look at. Technically, diagnoses, official diagnoses, are often given what you'd call post-mortem, and that is in order to really see what was going on with the brain, to really say for sure it was Alzheimer's and not something else. You may need to be doing a, looking at the actual brain. We'll leave it at that. Okay, but we do see generally what's going on. We can see with behavioral psychological testing what's going on and notice differences over time. Okay, so some of the things in the mini mental state exam are, I'll say, do you know what month this is? I'll say, do you know who the president was? A couple years ago. I'll say, I'm going to say 3 words, and then I want you to say them after me. Those words are apple, table, penny. Now you say them. And then they say them. And then I say, okay, I'd like you to try to remember those words because I'm going to ask you again in a few minutes. I hold up a pen and say, what is this? And they need to have word finding, right? So they need to be able to say pen. I will, write this on a piece of paper, close your eyes, and say, please read this and then do what it says. And the person should close their eyes. And many other things like this, right? So I would say, how many weeks are in a year? Do you know which direction the sun sets? Counting backwards, starting at 100 by sevens, right? So 93, and then from there, blah, blah, blah. And these are these things that we ask people. I've definitely had people come in that are really concerned about their cognitive functioning, and we do this exam and they do fabulously. And then I can say, hey, I know that you may feel like you're having some issues, but they're most likely appropriate age-related decline, and we're not too concerned about it. However, let's do this again in a few months, and we'll check in on this regularly just to, make sure that everything is going as it should. Okay. Now, we also have something called pseudodementia. Pseudodementia is, a false dementia, right? Pseudo, false dementia. Symptoms are usually caused by depression. They look like Alzheimer's. They look like a dementia, but it's usually, you'll also notice that the person is having severe symptoms of depression. So maybe they kind of don't feel like getting out of bed. They really don't feel like showering or doing those kinds of things. Nothing seems interesting. You have those depression symptoms, and with that, they also seem to be having trouble with concentration, trouble with memory. An antidepressant or cognitive behavioral therapy should be able to help that. Okay. So going back to Alzheimer's disease, here are your other two things that you want to know, right? So going back to your Alzheimer's flashcard, we've got our tangles and our plaques. Okay, so I always say plaques and tangles and plaques. That's Alzheimer's disease, okay? So the biological theories of Alzheimer's disease really try to explain the development of these abnormalities with these two different things. And one is first the neurofibrillary tangles. This is made up of a protein called tau. It seems to play a role in maintaining this, what they call microtubules, I've always heard tubular, whatever, tubule stability. So when we look at the brain, we see these neurofibrillary tangles. If you think about your brain, you probably don't want things tangled. And then we have these amyloid plaques. Okay, so plaques in general. It can develop 10 to 20 years before behavioral symptoms become noticeable. And they're one of the first events in the pathology of this disease. So again, if you think about plaque, you don't want that in your brain either. So general things, plaques and tangles with Alzheimer's disease, which causes a progressive decline. Okay. Alrighty, moving down here. Risk factors. It's highly heritable. So genetics plays a big part of this. And this is what makes this such a difficult disease for generations of people, because you have a woman who is taking care of her mother who has Alzheimer's disease. And not only is it a struggle because she is caring for someone with severe dementia and watching them decline progressively, but she also fears this may be me one day. And she looks at her daughter who's in college and says, oh my gosh, this may be my daughter one day, right? Caretakers for individuals with Alzheimer's disease, especially, adult children who are caretaking for their parents, therapy is fabulous for them. A place where they can actually talk about how stressful it is and how frustrating it is and how much they appreciate things and how scared they are for different things. Often these individuals do not come in for therapy because they feel like, well, they're not the one with the issue. Caretaking is extremely difficult. And you should encourage anybody you know that's doing that to also get themselves into therapy so they have a space to talk. Okay. Smoking cigarettes clearly is a bad idea in general, right? But also is not helpful if you're trying to avoid dementia. Obesity seems to play a correlational role. Lack of exercise plays a correlational role. Okay. Behavioral stages. So behavioral psychologists are really developing stages to maximize the daily functioning for people with Alzheimer's disease. When we look at individuals with Alzheimer's disease, we really want to increase their independence. We want to make sure that they are in, the least restrictive environment. However, in an environment that is safe, we really want to eliminate wandering. And that also tends to help eliminate aggression. So some individuals with Alzheimer's disease end up getting irritable and aggressive. Often they will walk out of their homes and wander, and then all of a sudden realize that they kind of don't know where they are. They kind of can't remember their address or how to get back, and they can't remember anybody's phone numbers. And often they end up picked up by, a police officer who then takes them to a psych ward, because that's what they're doing for their best interest. However, then it makes the individual even more upset and aggressive and upset and upset and upset. Okay. So we want to eliminate these things. Really providing, like I said, social support for caregivers is essential also. One of these things with people with Alzheimer's, if you or someone who is a caregiver, someone with Alzheimer's doesn't need to be told that they're wrong continuously. Okay? if they think that when you come in and you are their child, and they, for some reason, have kind of forgotten that, and they think that you are their best friend from college, fine. Fine. There's no need to continuously tell them that you are not. Because as long as what they know about you is that when you are there, they have a feeling that you are someone who they really like and that cares about them and that they have good feelings toward. That's what they're remembering. They're remembering that they have good feelings toward you. Whether or not they remember you are their child is less important than the fact that they remember that you are someone who makes them feel safe. Okay? If they had a spouse that passed away and they talk about their spouse and say, oh yeah, he went to the store, fine. There's no need to repetitively tell them that their spouse is dead. Because you know what? 10 minutes later, 30 minutes later, tomorrow, they're not going to know again. And you're going to spend every day reminding that person that their spouse is dead. Let it go. If they want the sky to be green and that makes them happy, fabulous. Sky is now green. I hope you kind of get that idea. And, you know, most of you will never have to be in that situation where you even have to think about those things. But for those who will, I hope you keep that in mind. There is a fabulous documentary. It's actually really difficult to get a hold of, but I'm going to write it down anyway. It's called Complaints of a Dutiful Daughter. And it is, it's a documentary that was done by a woman who is taking care of her mother who has Alzheimer's. And I just think it's one of the best movies ever. However, it's not streaming on anything that I've seen recently, and you often have to pay for it. I have been able to access it before through like interlibrary loan, and that's been really nice. But I haven't done that in a few years since I've been teaching online versus in class. But if this is a topic you're interested in, I think Complaints of a Dutiful Daughter is pretty good. Okay. Now, neurocognitive disorders due to neurological disorders other than Alzheimer's disease. Okay, so we're moving on from Alzheimer's. We've talked about it. We're moving on. Okay, so these are a few different ones. I do want you to know a little bit about the differences between these issues. Okay, so first we have frontotemporal neurocognitive disorder. Okay, so if you think about the brain and where the temporal lobe is, so we're talking about sort of the front of the temporal lobe, neurocognitive disorder. Okay, symptoms are reflected in personality changes. So we start to see apathy, lack of inhibition, which can be a problem, obsessiveness, and loss of judgment. So this individual really needs someone else to be helping with caretaking and making sure they are not making real bad decisions, real bad impulsive decisions. Okay, people tend to neglect personal habits, and eventually they have the loss of ability to communicate. This onset of this disorder is slow. It's upsetting to people who are around them. It's upsetting to the person. Fortunately for the person, they actually have this loss of inhibition and loss of judgment. So in a way, they kind of, you know, it's not that big of a deal. Maybe more upsetting to the caretakers at the time. Okay. Let's see. Neurocognitive disorder with Lewy bodies. Okay, so let's see. With this, I'm just trying to think of sort of how to explain this. Something I want you to know is with the Alzheimer's disease, if you remember, if you can watch my little pointer here, if you can think about with Alzheimer's disease, we have this sort of gradual decline like this, okay? in Lewy body dementia, we have what we call a stair-step decline. Okay, so they're going along, things are going okay, and then all of a sudden they have a pretty dramatic decline. And then they're going along and they have a dramatic decline. And then they're going along and they have a decline. Okay, so this is more stair-step-like. You're going to see this progressive loss of memory, language, the ability for calculation, reasoning, and higher mental functions. Results from the accumulation of abnormalities called Lewy bodies throughout the brain. So some of you guys wrote on Robin Williams, and it's hard to know sort of what exactly was going on with him. Obviously, there was depression, obviously. There may have been some other mental health issues going on, but people often talked about he had this Lewy body dementia. And what do we diagnose? How do we diagnose this? Well, we diagnose it as a major neurocognitive disorder. Okay. The next one we're going to talk about is vascular neurocognitive disorder. This results from a vascular disease that causes the deprivation of blood supply to the brain. Okay. Some people call this like a multi-infarct dementia. That is caused by transient attacks, which blood flow to the brain is interrupted by a clogged or a burst artery. Okay. Although each infarct is too small to be noticed at first, over time, the progressive damage caused by these things leads to the individual losing cognitive abilities. Okay, so with this vascular dementia, some people talk about like basically strokes or TIAs, things like that. Okay. The next one we're going to talk about here is Pick's disease. This is pretty rare, progressive dementia. It affects the cerebral cortex's frontal and temporal lobes. Okay, it seems to be caused by the accumulation in neurons and unusual protein deposits. With Pick's, in addition to memory problems, people with this disorder become socially disinhibited. They act either inappropriately or impulsively. They appear apathetic or unmotivated. So they become really inappropriate. Just if you can kind of think about if all of a sudden your brain was like fully socially disinhibited and you were impulsive and you like didn't seem to care about it, people that knew you well most of your life, assuming you weren't this way already, right? Assuming that you were like a general professional adult. All of a sudden you start acting this way and people are like, what in the world is happening with this person? Well, their brain is not working well. That's what's happening. But again, it can be upsetting when people see all of a sudden these behaviors and impulsiveness. So we really, want to get into the doctor if you have somebody who's all of a sudden like flashing people in public. Okay? Or maybe not that bad, but other things like that. All right. Personality alterations in this one really seem to occur before memory problems. Now, we also have neurocognitive disorder due to Parkinson's disease. And Parkinson's disease is more well-known, publicized. This is a neurocognitive disorder that involves the degeneration of neurons in the subcortical structures that control our motor movements. Now, if you remember back to when we talked about schizophrenia, I talked about schizophrenia and Parkinson's disease being on different sides of the dopamine spectrum, let's call it that. Okay? So, and I talked about if you have too much medication for schizophrenia, you start to have Parkinsonian-like symptoms. If you have Parkinson's disease and you are put on too much medication for that, you start to have schizophrenia-like symptoms. Now, at rest, your hands, ankles, or head may shake involuntarily. There's also what we call this akinesia. This kinesia looks, you should recognize this kind of word from kinesiology, if you want to break down words to kind of remember them. This is muscle rigidity, right? It's difficult initiating a movement. So somebody thinks about wanting to move their arm and they think about it and they think about it and they have to really put some effort into it and then it happens, okay? And while reaching out, they may shake. Medication is supposed to help with that stuff, but it still causes daily problems, obviously. We also have this bradykinesia. This is the general slowing of motor activity. People end up losing fine motor coordination. You start to see this slowed, shuffling walk, right? So their feet kind of shuffle as they walk. That's what gait means. Gait means the way they walk. Difficulty starting or stopping movements. Signs of cognitive deterioration. Expressionless speech. It becomes sort of stilted. One of the big issues with Parkinson's disease is that people know what's going to happen to them, right? They know that this is a deterioration kind of disease. And it can be really upsetting to think about, okay, here's how I'm functioning now, and I know what's coming. I mean, we all know that we're getting older, and we all know that, like, we're going to have some issue, and we're not going to live forever. But there's something, I think, that is more emotionally upsetting when you know exactly what the issues are going to be. And especially when they are these issues. Okay. Many cognitive functions, attention, concentration, immediate memory, things like that actually remain intact, right? So unlike the other dementias, these things are not as much of a problem. We're looking more at motor issues with Parkinson's. Okay, additional neurocognitive disorders. We have neurocognitive disorder due to Huntington's disease. This is also one you may or may not be familiar with. It's a degenerative neurological disorder that can also affect personality and cognitive functioning. We have this one due to prion disease. This is a neurological disease transmitted from animals to humans. People do call this mad cow disease. It leads to neurocognitive disorder and frankly death, resulting from abnormal protein accumulation in the brain. Then we have TBI, or traumatic brain injury, okay? This is where somebody has had a significant head injury. And I don't just mean like a concussion, but either like multiple concussions or serious traumatic brain injury, closed head injuries, or open head injuries. This is damage to the brain caused by trauma. This is a disorder where there's evidence of an impact to the head, along with cognitive and neurological symptoms that persist and past the acute post-injury period. Sometimes when you have an injury, you have issues right away, but then that goes away. This is if somebody has issues that aren't going away. All right, we have something called post-concussion syndrome. All right, so this should be shorter, right? This is a disorder in which you have physical, emotional, cognitive symptoms that persist for weeks to years, but they shouldn't be permanent, especially if you take care of yourself. They're experienced by people with mild traumatic brain injury. You see a lot of this post-concussion syndrome in people who play sports like soccer, football, etc., etc. Like, your head is your head and your brain is in there, and you probably shouldn't smash it against things. Cheerleading, we see this also with, stunts and gymnastics, like tumbling, falling on your head issues. Symptoms are going to include this fatigue, headache, dizziness, poor concentration and memory, headache and irritability, difficulty sleeping. And really what they'll have you do is rest. Although actually for some of them, it's the opposite. It's confusing. You should probably go to the doctor if you've had a serious concussion and you're having any of these symptoms, because there are different things they prescribe. And by prescribe, I mean recommend, based on what's going on with you. But if you have these weird, like, personality change, headache, continued things after having a concussion or having hit your head, especially if you've blacked out for a few minutes, you really probably need to see a doctor. Okay. Just to freak you out a little bit, right? We have neurocognitive disorders due to substance, medications, and HIV infection. A wide range of infectious diseases can cause these changes, whether that is neurosyphilis, encephalitis, tuberculosis, meningitis, HIV, localized infections, kidney failure, anoxia. Oh my gosh, there's so many things. I did tell you that there's whole classes on these things, right? It's a lot of information to learn. It's a lot to know about, and each affects everything slightly differently. I promise not to test you on the differences between these things. Okay? I do want you to know plaques and tangles. I do want you to know Lewy bodies. I do want you to know major versus minor cognitive. I do want you to know generally the differences between the things we talked about, but you're not going to need to know every single little tiny thing here. Okay. Now, there's also neurocognitive disorder due to another general medical condition. And that's actually the diagnosis, the whole thing. It was previously referred to as amnesia. Amnesia is really the inability to recall information that was previously learned, or the ability to register new memories. Okay? It can result from a wide variety of medical problems, head trauma, loss of oxygen, herpes, things like that. Don't freak out here. Okay? We're talking about, like, if this is something that is untreated and gets to your bloodstream and starts causing cognitive issues. Okay. Again, go see the doctor if you have issues. They can help you. Substance medication-induced neurocognitive disorders. This is the exposure of certain drugs or environmental toxins that can cause brain damage. The environmental toxins piece is why it is so essentially important that we do have laws and restrictions in place to make sure that businesses are protecting humans from lead, mercury, pesticides, things like that. We on our own need to be careful, don't lick the walls. You probably don't have lead paint, but just don't lick walls. Things like that. But we also need to be aware of the medications that we're taking. We need to, don't put certain drugs in your body. There are definitely ones, as we've talked about in the other chapter, that will cause your brain to not function for a long time. Okay, industrial solvents. You want to think about where you work, what you work around, really being careful about those kinds of things. And actually, now I'm hearing myself and I feel like I'm going to freak people out. Most likely you're just fine. Just be aware of stuff. Okay. Biopsychosocial perspective, as we always kind of end with, right? There's no real viable treatment for Alzheimer's disease. However, when we talk about, and by treatment I mean curable, we're not curing Alzheimer's disease. we are going to, with all of these things, have emotional support, have cognitive behavioral therapy to make things feel less bad emotionally. We have lots of different kind of computer networks, innovative technology methods, reducing stress placed on caregivers, things like that. There are medications. There are so many things because so much research does go into this area. We need to continue funding research in the area, in my opinion, so that we can continue moving forward with making life better for individuals that have these different types of neurocognitive disorders. At this point, the medications, the treatments that we have are to make things better, but not necessarily, quote, cure them. Okay. On that positive note, I'm going to go ahead and let you guys go, and I'll see you in the next chapter. Bye.